So our patient is a 9-year-old female, and we were originally dispatched to shortness of breath. So on the way there, we're thinking about what could be causing her shortness of breath, potentially. Could it be asthma, choking, bronchitis, pneumonia, something along those lines. Upon our arrival, we find the patient laying on the sofa. Her skin is pale and blotchy, toxic looking. That's a term that we use for people that are very, very sick looking. Her eyes are partially open. She's unresponsive. For circulation, there's no obvious external bleeding. She does have a strong, regular radial pulse. We're not too sure about her airway, but she is breathing rapidly and deeply. Since our patient is unconscious, we can't obtain a history of present illness from the patient, so we ask Mom. Mom says that she's a normal, healthy, 9-year-old female with no underlying medical problems. Yesterday she wasn't feeling very well, and she threw up at dinner. Now she can't wake her up. She has no recent history of falls or history of recent trauma. She has no past medical history or surgical history. She is on no medications, and she has no allergies to medications. For physical exam, her skin is pale, blotchy, and cool to the touch, and dry. Her pupils are equal and round, reactive to light. Her lungs are clear, and she's moving good air. Nothing else is remarkable in the physical exam. As far as vital signs, her blood pressure is 122/76. Her pulse is 130. Her respiratory rate is 40 breaths per minute. Her oxygen saturation, or pulse ox, is 97%, and her temperature is 98.4 degrees Fahrenheit. At this point, we do a fingerstick glucose using a glucometer on the patient, and it comes up as 443 milligrams per deciliter. At this point, Mom points out that the daughter drinks a lot of water and urinates a lot, and this has been going on for several months. Now the picture is becoming much more clear. We have a case of possible DKA, diabetic ketoacidosis. Now we're going to go into some of the biochemistry of what DKA is and how it's treated. So here we have a capillary, smallest blood vessel type in the body. And here we have a cell. And inside the cell, we're going to put a mitochondria, which converts the energy primarily found in glucose along with oxygen to release the energy stored in the glucose molecule. So let's put a bunch of glucose out here in the bloodstream. And the glucose normally is able to come into the cell with the help of insulin. Okay? And if we think about glucose as a $10 bill, one of the first things that we need to do to make change is to split glucose into two substances called pyruvic acid. So you're taking a $10 bill and you're splitting it into two $5 bills. And when you do that, you actually get 2 ATP. Now, if you remember from biology, ATP is the form of energy that our cells use. That's the whole goal of doing cellular respiration, is to produce ATP. Okay? So now, if we have oxygen, We can then take the pyruvic acids, put them into the mitochondria, and do Krebs cycle and electron transport chain. And the end result is 3 products: carbon dioxide, water, and about 36 ATP. So basically you're putting in $10 of glucose and you're getting 36 quarters. That's pretty close. Now that carbon dioxide diffuses out of the cell into the bloodstream. So that's normal physiology. Let's take a look now and see what happens with someone who has diabetes or has an issue with insulin or insulin receptors. So here's that capillary again, and here's the same cell. And here's the same mitochondria. Now, in this case, if a patient does not have insulin on board, they don't produce insulin or the insulin isn't effective, the glucose can't come into the cell, and the glucose is stuck out there in the bloodstream. Well, the cell still needs to produce energy. So what the cell does is the cell starts to break down lipids, otherwise known as fats. Now, the oxygen has no problem coming to the cell. The glucose, however, cannot. So lipids get split into glycerol and fatty acids. And it's these fatty acids that get metabolized and changed or altered to what we call ketones. Now these ketones end up in the bloodstream. So now we have glucose piling up in the bloodstream, raising the blood sugar because we can't get the glucose into the cells, has nowhere to go. So it stays in the bloodstream, and now we add ketones. One of the problems with ketones is that they're acidic, so they're going to lower the pH of the blood. Okay? So let's keep this in mind. So if you remember pH, it goes on a scale of 0 to 14. 0 are acids, 14s are bases, and 7 is neutral. If you have a pure acid, you have pure H pluses. They're called protons or hydrogen ions, actually hydrogen cations. If you have a pure base, you have OH negatives. That's all you have. Neutrals have an equal concentration of both. Now, our arterial pH, the pH in our bloodstream or in our arteries, should be around 7.35 to 7.45. But the problem with ketones is now we are driving the blood's pH closer to 0. We're never going to hit 0, but it drops the pH. Okay? Now, let's go back. If you remember from biology, we have cellular respiration. So the products of cellular respiration, CO2 and H2O, don't worry about the ATP for now, these guys combine and they form a weak acid called carbonic acid, H2CO3, which rapidly breaks down to form HCO3 minus, which is called bicarb, and H pluses. Now, H pluses, as we just said, are protons. The problem is that if we increase the amount of CO2 in the bloodstream, we increase the amount of H pluses, which means we drive our pH even lower, closer to 0. So, not a big deal normally, because we just get rid of that CO2. And if we get rid of the CO2, then we can get rid of the H pluses, and we can raise our pH back to normal. So normally what happens is we have chemoreceptors, and they sense a change in pH. They don't really know what's going on, so they send impulses up afferent sensory pathways to the integration center. In this case, it's the brain. The brain realizes that our pH is dropping, and the brain knows that if we can get rid of CO2, we can lower our hydrogen ion concentration. So what the brain does is the brain integrates it and decides, hey, we've got to blow off more CO2. So the brain decides we've got to breathe faster and we've got to breathe deeper. So the brain sends impulses down efferent motor pathways and therefore increases our respiratory rate to blow off CO2 in an attempt to try to get our pH back to normal. Makes sense. But the problem is that excess CO2 isn't the problem. The problem are ketones. Ketones are causing the acidosis. But the body doesn't know that. So the brain says increase the respiratory rate, increase the depth of respirations. And we end up with a pattern of very deep, very rapid respirations that are called Kussmaul respirations. And they are one of the indicators of diabetic ketoacidosis. They are also one of the indicators of plain old acidosis. In the normal person, we can measure their CO2 being exhaled. And in a normally functioning person, the end tidal CO2 or EtCO2 should be between 35 and 45 millimeters of mercury. Hers was 5 millimeters of mercury, which is very, very low. And that was further evidence that her Kussmaul respirations were actually blowing off too much CO2 in an attempt to raise her pH. So, in order to treat her, we need to maintain her airway, establish an IV or an IO, and paramedics in Pennsylvania cannot administer insulin, so we need to get her to the emergency department where the nursing staff can then start an insulin drip and potentially transfer her to a pediatric specialty hospital.